Hello, Ria.
Hello, hi, good
Hi,
evening.
good evening. Should I just check to share the screen?
Yeah, yes, please.
Yeah, is that visible now?
Yes.
Okay, and right square. Yeah, this is all right. Visible? Okay.
Yes.
Yeah,
Yeah.
so then we are done. We'll stop share.
Ma'am, we'll just wait a couple of minutes because
Okay.
everyone's still getting admitted to the meeting.
Yeah, okay.
Yeah.
Sure.
Good evening, Sirisha,
Hi,
ma'am.
Ria. Good
Hi, ma'am.
evening. Started?
We'll just start at 6:05 because people are still getting admitted to the meeting. Yes.
Hi, Ji.
Hello.
Hi. Hi, Shalja. Hi,
Hi.
Sushmita.
How are you?
Sushmita. Hi, Shailja.
Hi. So who's presenting first? Dr. Sirisha?
Can I?
Yeah, whatever you guys decide.
Yeah. I've rushed and come from the OPD. I'm not done yet.
Oh, then you finish first.
Yeah. Okay, I think then we'll start.
Yeah,
We'll
yeah, we
start.
should start.
Yeah. So then I
Okay.
can at least connect on the phone. I can run away from the laptop.
All right.
Yes, yes, yeah.
Okay, so good evening, everyone. And today is our 11th session for Ocular Genetic Interest Group meeting. So next one is going to be 1 year of starting this initiative, and we are having more and more members join us. So that's great. Today, both our sessions are going to be related to glaucoma. We have Dr. Sirisha again with us, and today she's going to be talking about LTBP2 and the phenotypes it presents with. And now over to you, ma'am.
Yeah. Thanks, Ria. I think this is a fantastic forum, and I always look forward to being here and learning so much. And so I would like to and possibly this is more importantly to create awareness about this condition. So let me start with this. So, yeah. So this was a child who was 4 months old, brought to us by the parents because of enlargement of both the eyes, and they had visited a local ophthalmologist who diagnosed congenital glaucoma and referred the baby to us for surgery. Okay, so this is the second child born to consanguineous parents. And the child definitely had very large corneas. There was corneal haze noted more in the right eye compared to the left eye. And both eye also had, right eye had a little mid-dilated pupil or about 4 millimeters, and the left eye had a small pupil. There was some whitish appearance present in the pupillary margin, and there was gross iridodonosis noted. And there was subluxated lens noted in both the eyes. Now the question is this congenital glaucoma? So we were not very sure. So we took the baby up for examination under anesthesia, and the And these are the pictures taken under anesthesia. So the right eye had, both the eyes had enlarged corneal diameter, 13.5 millimeters in both the eyes. There were no HABs striae. The refraction was -16 in the right eye and -14 in the left eye. There was corneal edema noted more in the center compared to the periphery. And there was some whitish appearance in the pupillary margin in the right eye, and left eye had a similar kind of an appearance, but had a persistent pupillary membrane that was in the center with few tags stuck to the pupillary margin, and the pupil was, both the eyes pupil were not dilating beyond this. There was a grossly subluxated lens to an extent that it was dislocated posteriorly, more in the right eye compared to the left eye. And the intraocular pressures were 2 millimeters mercury in both the eyes. In fact, both the eyes, the lens were quite wandering. And in the right eye, it looks like maybe the lens was coming in the front, touching the cornea and going back. Left eye, maybe because of the presence of pupillary membrane, it was not coming into the anterior chamber. Cup to disc ratio was normal in both the eyes. B scan showed attached chorioretinal complex and nothing else, except that you see that the reflectivity of the lens here that is seen is slightly more posterior compared to what you would normally see. So this was the clinical picture. The corneal diameter greater than 11 millimeters in a very young baby, and more than 30 millimeters at any age. We know that enlarged corneal diameter is one of the classical features of congenital glaucoma, and there is corneal edema as well. So you have enlarged corneal diameter, you have corneal edema, but intraocular pressures are normal. And very high myopia. That high myopia is possibly secondary to the lenticular myopia because of the spirophakic lens. So this is not congenital glaucoma. And this child underwent a pars plana lensectomy and vitrectomy. What was also interesting was in the peripheral retina, there were some changes that were noted that was consistent with a lattice kind of a degeneration. And this child underwent a peripheral retinal laser as well. The first picture is actually not this child's. This was the elder sibling of the same child. You can actually see that there is some glaucomatous changes that are noted in the disc. This disc is this photograph, as well as this photograph is that of this baby only. Post-operatively, the child had a refractive error of +13 in both the eyes with a cylinder, and the intraocular pressures were normal. And over the past several years, now this was 2 years when I actually put this together, but the child is now, I think follow-up is close to about 3 years now, and the child is not on any anti-glaucoma medications. And when asked for history, they said the elder sibling also keeps whatever object you give, keeps the objects very close, keeps it very close to the eye and sees, but otherwise they have not visited the ophthalmologist. So we asked the elder sibling also to be brought to us. And when we examined, this child also had spirophakia with very, very high myopia. And this child also underwent bilateral lensectomy with pars plana vitrectomy. So the features of megalocornea, presence of ectopia lentis and spirophakic lens, either they can be dislocated or grossly subluxated, may or may not have secondary glaucoma. These are the features that we have noted. And obviously, we need to rule out primary congenital glaucoma. So classical PCG with HABs striae has HABs striae with enlarged corneal diameter, may or may not have elevated intraocular pressure because the globe is kind of enlarged. So this child did not have HABs striae but had only enlarged corneal diameter, did not have any other feature, no elevated intraocular pressure, no posterior segment involvement of the optic nerve. And we also have to rule out another condition, which is congenital megalocornea, which also can present with similar kind of picture, but often they do not have ectopia lentis. So the horizontal corneal diameter can be enlarged even to as great an extent of 15 millimeters of millimeters. They have very thin corneas. They also will not have the intraocular pressure may be normal, but the lens will usually be normal and there is no ectopia lentis. So whenever you come across, so the two things that we need to differentiate, one is enlarged corneal diameter, the second one is ectopia lentis. So enlarged corneal diameter, we need to rule out primary congenital glaucoma, which often has HABs striae, especially when the corneal diameter is more than 13 millimeters. And the second one is congenital megalocornea, that was also ruled out for this baby. and ectopia lentis. There are several causes of ectopia lentis: Marfan syndrome, homocystinemia, Weil-Marchesani syndrome, and the other uncommon conditions also that we need to look at, where you can see some of these syndromic associations develop full-fledged features only when they are older. When the children are very young, sometimes we may not be able to differentiate them from a Marfan's or a Weil-Marchesani syndrome, but we need to rule out all of that. And that brings us to another common condition where you can have congenital megalocornea and have ectopia lentis, may or may not have secondary glaucoma. The condition is LTBP2 mutation. So clinical exome sequencing was done, and obviously we could see that there was LTBP2 mutation was noted, and they were homozygous autosomal recessive, and the similar kind of mutation was seen in the other sibling as well. So the parents were consanguineously married, and then parents obviously also were carriers for the same genetic mutation. They were not affected. So just to reiterate, what are the features that we typically see in these patients? They have megalocornea, they have no HAP striae, they have gross iridodonosis because there is no posterior segment support. They can have persistent pupillary membrane. Sometimes they can also have ectopia and UVA. They can have posteriorly subluxated crystalline lens or a dislocated lens. And you can also see some of these lenses are also called as wandering lenses because they are small. They keep moving from the anterior segment because one anterior segment and posterior segment. There was one child who was seen in the emergency with an anteriorly dislocated lens. And by the time we went to the, from the clinic when we were called and went to the emergency to see, which is just one floor down, the lens had gone back. So it keeps moving from front to back, and we need to be careful in examining these patients. Very interestingly, what we found was when these patients, in fact, we have a few of these children, when they were presented to us with a primary combined trabeculectomy done elsewhere because they were diagnosed as congenital glaucoma, invariably they will present with a posterior segment pathology. They can have either a suprachoroidal hemorrhage or they can develop a retinal detachment, and they may even lose the eyes. So they do not have glaucoma, and we should not be operating them for glaucoma primarily. But if the subluxated lens is there for a long time and recurrent pupillary block, or sometimes they can present with iridocorneal adhesions, they can even have a flat anterior chamber, they can develop secondary glaucoma at a later time point. They also have this peripheral lattice, which is what we need to be very careful when even when they are doing the lensectomy, we have to be very clearly discuss with the vitreoretinal surgeons that if they notice this peripheral vitreoretinal pathology, that retinal pathology that they see, they may require a peripheral retinal laser because these eyes, even spontaneously, even without a glaucoma surgery, they can develop a retinal detachment. So we need to be sure that if at all they undergo a lensectomy, also the peripheral retinal evaluation has to be done. If necessary, it should be lasered so that you can prevent the retinal detachment from developing. So these patients, and these are some of our other patients whom we had tested, whenever they have this typical phenotype, we have to be very, very clear that genetic testing has to be done. And if they have siblings in the affected similarly, we also need to call them and evaluate them, and parents also need to be evaluated. These are some of the known mutations for LTBP2. It is seen mostly, there have been reports from Saudi Arabia and from Pakistan and Iran as well. And there are several mutations that we saw in our own cohort, which were different compared to what is already published. So what I would like to show is the study that was done by Shi et al., published in 2021, a very beautiful study that was done. This was an animal study that was done, which actually tells you what happens in these patients. So LTBP2 is nothing but latent transforming growth factor beta binding protein 2, which is it necessary for the zonules to form? Is it necessary for the strength of the zonules? And how does it affect the ectopia lentis, or how does this particular problem happen? So the function of LTBP2 is not something that is very clearly understood. Some studies have said that it could have a critical role to play in the development of the eye itself. And they may be structurally and functionally homologous to fibrillin 1 and fibrillin 2. But what is important to know is that the deficiency of this particular LTBP2, when they have a mutation, can actually cause subluxation of the lens because it causes the zonules to fragment. So this is the experiment that actually showed. If you look at the panel A here, it is the ASOCT images of the LTBP2 null mice as well as the wild type. And the panel in this A image, the left hand side images are for the ones which was the wild type, whereas the here on the right hand side is the one with the null mice, LTBP2 null mice. That means the mutation that is occurred. So here the anterior chamber, generally in children, if you see, as well as in the mice, when the mice is just born, the anterior chamber is very shallow. As time goes by, it may deepen a little bit. But if you see here on the right hand side panel, the iris position keeps on going backwards. So which means that there is subluxation of the lens that is happening. And this is the backside view where the C is the at 1 month for the wild type, where there are this is not the wild type. I think the C and D are for the LTBP2 null mice, where there is a loss of zonules even at 1 month, and at 6 months you see there is a significant loss of zonules. Whereas the E actually represents the LTBP2 wild type, where there is no loss of zonules. So that means even as early as 1 month and 6 months, you can have significant loss of zonules, breakage of the zonules, and that can cause subluxation of the lens or the dislocation of the crystalline lens. So this is to understand that this is a very, very distinct ocular phenotype, means it's a clinical diagnosis. And why this particular pupillary membrane that they develop, I have no idea, but the LTBP2 also has something to do with the resorption of the pupillary membrane as well. So they have enlarged corneal diameter, no Hab striae, they have distinct pupillary changes, which even clinically from outside you will be able to make out. They have such gross iridodonosis, even with a torch you can see the tremulousness of the iris. Otherwise, many of the children with aphakia we see, but don't see so much of a tremulousness. But they can have it even at a very young age. You can have, often you see posterior dislocation of the lens, but you can have subluxation of the lens if they're presenting early. Typically, if they're present very early, meaning like 3 months, 4 months, 5 months, the treatment is to do a lensectomy. Do not even wait, because when you're doing a lensectomy, examine the peripheral retina, make sure that the peripheral retina is treated for those, if they have peripheral retinal degeneration. Even if they don't have it, the tendency for them to develop an RD is there, so they need to be evaluated. And over the long term, even glaucoma can develop, and they also need to be followed up for glaucoma.
Thank you, ma'am. That was great. And we too have had a few patients who have, we could not correlate before doing the testing that these were LTBP2, but they fit the phenotype exactly. We see the ectopia lentis and the other things as well, as you mentioned. I will just take questions from the audience.
Yeah, I have a question. Pooja, are you speaking? Are you asking a question?
Yeah, can you hear me? I'm
Yeah, please go
actually
ahead.
just on a flight. I don't know if you can hear me. Okay,
Yeah,
Yeah,
can
we
hear
can
you.
hear you.
thank you,
You better
ma'am,
hurry
for
then.
this. Excellent. Yeah. Just before I take off. Okay. So, I have this one child who's a 4-year-old with the same megalocornea with a microsclerophakia subluxation, and the pressures were actually normal, like it fits in this phenotype. But the patient had like a persistent pupillary membrane with some iridocorneal adhesions and like the field regal kind of clefts
Yeah.
in the iris.
Yeah.
So I wanted to know if any of you have seen that. We've not been able to do a genetic testing on the patient because it's been advised, but the patient hasn't followed up because of monetary reasons. And this was at 4 years of age. Visual potential has been very good. She's doing very well.
Yeah.
But I wanted to know if this kind of fits into it, or is it like an accidental rigor with a microspherophakia, which subluxates? I don't know.
So
I
accidental
mean, I haven't
rigor,
looked at the latest degeneration, honestly. I mean, I'm going to go back and see this. But
yes. Yeah. So, I mean, megalocornea without HAP striae can also be present in other conditions. And axonfil rigor, I think we need to be, it is bilateral, and sometimes because of the subluxation of the lens in these patients, if the subluxation is in such a way that it kind of gets displaced towards one side, then you can have iridocorneal adhesions and you can have a flat anterior chamber as well. So iris can present in multiple ways. So you can have that, but if there are no other systemic problems, there's no changes in the philtrum that you see, there are no problem with the teeth, and other things that you want to really look at. Autosomal dominant is the condition that axonfil rigor that you're talking about here. It is often recessive, but just otherwise having a clean eye with no posterior embryotoxon, no nothing else, but just having the iris changes, I wouldn't put that as axonfil rigor. I think we need to look at all the other features as well. And we definitely need to do a genetic testing. Clinically, you can make out. I mean, both the conditions can be clinically differentiated. But having said that, I think if you want to really confirm the diagnosis, you need to do a genetic testing. Look at the parents, look at the other eye, look at how the changes are. Is there any prominent?
so if there is no posterior, yes, okay. Got it. All right. Thank you so much. I'm just going to mute the.
Dr. Shailja?
Sirisha, yeah. I was asking that I think I've shared in the group also. I mean, because LTBP2 and this subluxation kind of phenotype along with megalocornea is being discussed. Has anybody seen this in unilaterally with confirmed LTBP2, or is it always bilateral? Because I think I remember, if you remember in the group, I shared a child which I had seen where there was a unilateral megalocornea with ectopia lentis, which was again, now the lens was pushed to one side. It was not like, the spherophakic lens and falling anteriorly or posteriorly. It was just shifted to one side. Lens was clear. Pressures are okay. It's just that defective zonules in one particular area. And the other eye is absolutely normal. So has anybody seen something like that?
Yeah, unlikely, Shailaja. See, they can be asymmetrical. But having said that, it is a bilateral problem. The zonules are lost and the zonules are lost. So one eye you can have a dislocation, other eye you can have a subluxation, and megalocornea is bilateral. So megalocornea is not in response to the elevation in intraocular pressure. Primarily there is a megalocornea in the development itself. So there is something wrong with normally cornea will arrest, right? By the time it reaches a certain size. But here there is some abnormality in that arrest of the development. So the ciliary ring itself is very, very broad, or rather large, because of which the cornea itself is enlarged. It's not in response to the elevated intraocular pressure. But let's say you can have one eye 14 millimeter, other eye can be 13 millimeter. Like you can have a difference in size, but it's unlikely that one eye is enlarged and the other eye is normal. So in the cohort that we have, there is one patient who has a 12.5 millimeter corneal diameter, proven LTBP2. So you can have a variability. It's not like always everybody has beyond 13, but majority of the patients, like if I have about 18 patients, all of them have it beyond 13 millimeters, but there's only one child who had it around 12.5. We did a biometry as well to get the white to white, and we also calculated it clinically just to make sure that you have more than one test to know if it was so. So apart from that, majority of them have it enlarged, but you can have it asymmetrical.
So Sirisha,
so that patient again,
sorry.
Yeah, ma'am.
Carry on. Sorry.
No, sir. No, I'm saying I have not sequenced that image, sequenced that patient. So it's still in the pipeline. Parents are not yet convinced for it, but definitely once I do, I'll let the group know what happens, because there's no history of trauma, no history of any other perinatal or antenatal problems. It's just one eye, that phenotype, which is very similar to LTBP, but just unilateral.
Yeah, no, because
Yeah.
why I am so concerned about these children is that depending on which clinic it goes to a pediatric clinic, high myopia, ectopia lentis, lensectomy. No problem, do a lensectomy. But what is important is that even after lensectomy, in fact, we've had a child, they're two cousins, two sisters married to two brothers, and each one of them has one daughter, and both of them have the similar kind of problem. Lensectomy done very well, absolutely no problem. One child, actually one of the younger ones was brought to us 4 years later. They were brought to the cornea clinic. In fact, Murli had seen that child because they brought the child because the child had developed a BSK, because of which there's some amount of haziness in the cornea. So iske liye leke aaya. But why BSK? And the child actually had an RD in that eye, and there was obviously not treated. And because of chronic inflammation and things, the child developed a BSK. And they actually came for that and not for the vision. And that eye had a chronic RD, and the contralateral eye has a very shallow RD. The only seeing eye has a shallow RD. The child had to then undergo a retinal surgery, and then she developed glaucoma, and ultimately I had to do a glaucoma drainage device surgery. And that eye she is able to see now. Her cousin, the elder one, the other cousin that I was talking about, exactly similar kind of a picture, bilateral lensectomy done elsewhere, and then they were not thinking of surgery was done by a good vitreoretinal surgeon, no problem. But because the children have very abnormal vitreal adhesions in the periphery, they don't really shave the peripheral vitreous, right? So there is some traction that has happened, and this child has developed bilateral RD, one eye no PL, and the contralateral eye now RD surgery with oil, and children में ये सब करने को कोई ज़रूरत ही नहीं है. And to a great extent, I think we can prevent it. So if it goes to a vitreoretinal surgeon because of subluxated lens, they will do it. It's fine, no problem, do it. But make sure that the periphery is like your Strickler's syndrome. Everybody knows RD is a problem in them. Like that, I think we need to make sure that it's not just the subluxated lens and glaucoma, but we also have to make sure that the retinal problem has to be evaluated and treated. Every single child. Now, I mean, if the retinal surgeon takes care, I am behind them. Examine the peripheral retina and laser it and fix it. It's not like you see a hole and hence you laser, but since their tendency to develop RD is so high, in our cohort we had seen more than 20% chance that they will develop RD. So which means that every fourth or fifth eye will have it. So might as well laser it.
So Sirisha, what I was asking was the child who had...
It's like a peripheral barrage laser, whole 360 degrees.
Yes, peripheral barrage laser. So Divya Balakrishnan, who used to be our pediatric surgeon earlier, and now...
So should it be done, like, have you done prophylactic laser?
Yes. Now we do that. Prophylactic. All of these children, you evaluate peripherally. If there are no peripheral retinal lesions, no nothing, no laser. I mean, unnecessarily, obviously, you wouldn't want to see eyes. And they are followed up every year, even with the vitreoretinal surgeons. But if you see peripheral retinal lesions, and also when they're doing a vitrectomy, lensectomy, induce a PVD and do a complete pars plana vitrectomy. It is difficult, but I think if they know that this is because the vitreous traction is what will cause the problem. So peripheral retinal, the vitreal adhesions have to be completely removed. Yes, Sushmita. Sorry.
So I was asking you in the child who had the 12.5 millimeter cornea, was the lens normal in shape, or was that
No. That was also subluxed. All features were similar.
Really? Okay, because I have a couple whose lenses are normal in shape and they present as PCG, and some present as unilateral. So, and they're all, and we weren't expecting LTBP2, but we've seen them. But I'm not sure whether there is a phenotypic heterogeneity of this gene as well. Because
you can have.
we've done UBMs, we've done the ASOCT, the lenses are completely spindle shaped, good zonules. They come with unilateral PCG, one has come with bilateral PCG only. So we diagnose them as PCG. Unilateral PCG is another bone that I pick. So I try to genetically see why is it that only one eye has this thing. And I'm surprised that a couple of them have had. So I've now come to, of course, when you have spherophakia and you have a large clear cornea with no harbs and no edema, my first take would be LTBP2. That's one red herring, that if there's a large cornea and it's a high myope, it will be LTBP2. But I do have maybe 3 or 4 children with absolutely normal lenses, unilateral PCG, and LTBP2 as well. And like you said, there are 35 exons, so we really don't know which domain. And that one thought that it is also concerned with development of the eye and not maybe just the zonule. So maybe we need to keep that in mind as well, because I've seen that. Yeah.
So there are there is one patient who we also had where there was LTBP2 and something called as a P-care. I don't know what that is. And then that was possibly associated with glaucoma and some retinal dystrophy. So there are some patients for whom you have some heterozygous involvement, and these children typically don't have ectopia lentis.
Yes.
So when you do when you do a whole exome sequencing, I think multiple things come out. But like these patients, at least who have typical features. In fact, Dr. Deepika used to help us with the vitreoretinal surgery as well. So those who have very, very typical features, they only have LTBP2. They don't have any other mutation in any other gene. So we don't know. I'm sure 2 years from now, 5 years from now, we may speak something differently, or we may say that, this may also be
the only point is that it's not the only phenotype. It's important to remember that. LTBP2 doesn't, it's the other way around. Most spherophakias and clear corneas, large megalocorneas would likely be LTBP2, but the reverse may not be true, that all LTBP2 will have just this phenotype and not any other. That's something to keep in mind.
Agree.
Dr. Deepika, you had a question as well. If you want to unmute yourself.
Okay, yeah, thanks, Riya. Hi, ma'am. Sorry, I joined a bit late, so I'm not sure.
Deepika used to help us with all these babies.
Oh, no, I learned LTBP2 from madam only. Maybe I must have done so many lensectomies for LTBP2 and never realized that it was LTBP2 before. So that's what I learned through this. Ma'am, I wanted to ask, I remember you were trying to analyze the type of mutations to the spectrum of clinical features, like whether it was the anterior segment signs or development of RD and peripheral retinal lesions. Could you find any correlation, ma'am, in that, like severity of mutation to the clinical signs?
Not really, Deepika.
Okay, ma'am.
We could not. I mean, it's difficult to really figure that out because of the so there were 12 different variants that we found, and half of them were in the first half of the protein and the half were in the second half of the protein. So we tried to see if the early part of the protein was affected, then would they be more severe and things like that. So we had some hypothesis, but then we could not really prove anything because RD happened in anybody. Yeah, and also we looked at whether the age of presentation and the severity of the disease, including presence of glaucoma, was there any relationship? We could not figure out. So only thing we found out was if lensectomy was done late, meaning if lensectomy was done beyond the age of 1 year, the tendency for them to develop glaucoma is very high. In fact, there was a presentation in, where was this? WSPOS, I think. There was a Greek, from Greece, I think there was a doctor who was presenting on similar type of thing. And they were saying they wait typically for more than 1 year, when the age is more than 1 year, for them to do a lensectomy. I don't know why they waited, but That's what they were saying. And then most of the patients had glaucoma in their cohort. So at least our understanding is, I'm sure you'll remember, Deepika, so the younger they are, their discs are healthy.
Yes, ma'am. Absolutely.
So
Yes.
if you leave them for a little longer time, obviously because the lens is wandering all over the place, they will develop intractable glaucoma. So
Yes.
the lesson that we learned is do an early lensectomy. So how early can you do? Even in our own cohort, the youngest child whom we could pick up was 4 months. And in that Shi et al.'s paper also, it showed that the lens zonules can break as early as 1 month. Why this happens is because of the saccadic movement. So the zonules are so brittle that even with general saccades itself, you can have the breakage, and that they're more than 3 months, it is only going to increase. As the child fixates, as the child is going to move the eyes more, they will have it. So as early as possible, as early as third month, fourth month, whenever you see it, remove the lens. So people may question and ask, like, removing the lens, is it safe? Of course, leaving the lens is going to cause more of a problem. Removing the lens may not be the safest, but yes, safe when you have to do the peripheral retinal evaluation and take care of the retina as well.
Yes. Okay. Thank you, ma'am. Thank you. Nice.
Thank you, ma'am. That was a great talk. Thank you so much. I know you have patience to get back to as well. And we'll move on to our next talk for today. We have Dr. Sushmita. Bye, ma'am. We have Dr. Sushmita Kaushik from PGI Chandigarh, who will be briefing us on genetic testing protocols in the clinic. So over to you, ma'am.
Right. Thank you. Thank you so much, Ria, for having me on this forum. I really, really look forward to all the things, and I've learned so much. So this is really an overview and an outline of what is possible, and very, very early baby steps of how, as a clinician, we use it in the clinic. And there are also some stories of how we are hopefully wiser and our experience guiding us for appropriate testing strategies. So we know these are the tests available, but we are fortunate now that the cost of even a whole exam has become quite affordable. And that's a relief because we can possibly understand more about the phenotypes that we are seeing. So the questions that I had when we had the opportunity to do the whole exam, of course, was what is the genetic profile of childhood glaucoma in our part of the country? We had no idea what we are seeing. And it is well known that different populations across the world and different ethnicities are very different, because what might be a pathogenic variant in the Middle East might just be a SNP for our population, and we didn't even know that. And the second question was, can we use this information to guide us towards an appropriate genetic testing strategy for our patient? Or can we learn enough about a phenotype to not even require genetic testing ultimately? So, so this 5-year retrospective study, I just put this together. We diagnosed glaucoma strictly using the CGRN classification, which is now standardized worldwide by both the American Academy as well as the World Glaucoma Congress. So we've categorized them. And we, of course, first send them to for genetic counseling by a geneticist. And then an appropriate genetic test was ordered. And the pathogenicity of variants were determined using ACMG guidelines, and then we compiled and analyzed our data. So this really is a very, very busy slide, and I've put together about 210 babies that we had over the last few years. And so in our cohort, the phenotype, now this was very, very deeply phenotyped. So these are all phenotypes which are done on the EUA. So there's no ambiguity in the phenotype. That's one thing that I'm very, very sure about. So 30% were PCG, which means nothing except a trabecular dysgenesis. And in this cohort, about 1/3 was CYP1B1. But like I said, we did have a couple of PTEX2, we did have LTBP2, we did have some others. Neonatal onset CU was something that we saw, and I think was erroneously called a severe congenital glaucoma, until it's not just a PCG, it's a very, very bad intractable glaucoma. In our part, it's 1/5. So 1/3 are PCG and 1/5 are neonatal onset CU. So that forms the bulk of the phenotypes that we see. And 82% of neonatal onset CU is one variant, which is the arginine 390H of CYP1B1. So this was quite a surprise to us that almost half or more than half our patients are comprised of two phenotypes. The rest we had Axenfeld, about 15%, of which 27% are FOXY1, but 18% was CYP1B1 as well. We had about 10% of aniridias, and most of them, more than half, were PAC6. We'll talk a little bit about aniridia later as a phenotype. Peters was the enigma. We have no idea what causes that horrible Descemet's defect and horrible cornea and glaucoma to boot. But this is something which possibly will need a whole genome sequence because we have no idea what's going on in this one. Microspherophakia that we saw, 100% LTBP2. So like we said, if you have microspherophakia and a large cornea coming to a glaucoma clinic, all 7 children had LTBP2 mutations, but LTBP2 also presented with other phenotypes. CPA, of course, we had 4 of them. Most of them were FOXY3. JOAG was just 2. Neurofibromatosis, again, we had 5. All of them were NF1. So this is, again, 100% concordance. If you diagnose neurofibromatosis correctly, all were NF1. But these are rare diseases. Sturge-Weber, of course, will need a whole genome again. Rubinstein type B, Stickler's type 2 collagenopathy were all concordant with whatever the genes they had. So what does this all mean? If I can just put this together in a nutshell, what this means is out of these children, 210 were non-acquired glaucoma. And we actually did acquired glaucomas as well because some of the cataract surgeries, the steroids, the traumas, we didn't understand why they should have because it didn't seem. So we just wondered, is there a genetic preponderance as well? And is that what is causing the glaucoma? So as I said, these were the phenotypes and they were pretty much typical: PCG, neonatal onset CU, bad glaucoma, Axenfeld-Rieger, aniridia, Peters. And pathogenic variants were seen in more than half the non-acquired, which is much more than what is reported. And I think it's not that the penetrance is more now or anything. I think the phenotyping is better. So most of older literature would talk of congenital glaucoma and then say 20% positivity for CYP1B1. No, but it's not congenital glaucoma because it's not PCG. It also includes, the definition would include ophthalmos, hazy cornea, raised pressure equals quote-unquote congenital glaucoma. But that's not true. We know that now. So the importance of deep phenotyping for a clinician is very, very important. And that's when you're going to get more robust genetic information as well. But then 22% were classified as VUS. We need RIA's help and all the help that we can get to get around what this VUS is and is it actually pathogenic for our population or not. GWAS studies are needed and I don't know how and when we are going to do that. So like I said, there was a high genotype-phenotype concordance, 100% with microspherophakia, neurofibromatosis, Rubinstein type B syndrome. So if I diagnose this, the implication is if I diagnose this entities now, I probably would not do a genetic testing. So that's how it's changed. Otherwise, we used to be doing genetics because there was a question, dekho kya hai? So there's no dekho kya hai anymore. I know there are conditions which are going to be concordant with one genetic diagnosis, and possibly I would say koi zarurat nahi, we're going to see the same. The next was a significant concordance of neonatal onset CU, aniridia, and congenital primary aphakia. These were all more than 70-75%. So you have a fair idea that if you have, this is classic CPA. I know it's possibly going to be FOXE3. So unless the parents want genetic counseling or they want information on the next child or something like that, aniridia for that matter, if you know if you have a sporadic PAC6 and the parents are normal, it's most likely a de novo mutation, which is important for the child's further children, but I don't think it's important for the parents' next child. So things like that, for that's what we would possibly do a genetics for. There was a moderate concordance in PCG, 41%, and a very low concordance in Peters anomaly. So Peters, we really had no idea. Considering the acquired glaucomas, surprisingly, post-laser for ROP, I mean, ours is a very, very heavy ROP center, and we hardly see glaucoma. But when we see it, when we did the genetics, we had a tech variant post-laser, and we actually had to do a goniotomy in the other eye. So it was a child with PCG with a tech mutation who just came early and iatrogenically had ROP as well. So it doesn't take away from the underlying thing, but it's just that we did the genetic testing and we caught the kid before actually it was born, because it was 38 weeks when we caught it. So we had 2 with PAC6 and FOXC3 variants post-cataract surgery. Very, very bad glaucoma, ophthalmos in almost 6 to 8 weeks. We couldn't understand what's going on. And our pediatric cataract surgeries don't have so much of glaucoma at all. They're very, very stringent with it. So when we did that, both of them, one had PAC6 and one had FOXC3. Again, a predisposition, a preponderance, which possibly was compounded by the presence of a cataract. And once a cataract surgery was done, they really developed very bad glaucomas. And one steroid-induced glaucoma, which we couldn't understand because it was one eye unilateral and the other was normal and all that. It was FOXC1 with more severe phenotype in one eye compared to the other. So genetic testing also, humblingly, we in all humility, it led to reclassification in about 2.9%. So we did all right. At 234 phenotypes, we were wrong in 11, and we had to reclassify them. A case in point is a PCG, newborn PCG turned out to be neurofibromatosis. And when we lifted up his shirt, we were stupidly looking at ourselves because there were cafe au lait spots, a couple of them, which we didn't see earlier. So let's see what happens in the clinic. So this is the story of that baby when we didn't know better. 3-month-old unilateral ophthalmos, diagnosed as unilateral PCG, which had no idea. CTT done, cornea better. 1 year later, again, the pressure started rising, did an additional goniotomy, noticed a bit of ptosis. And then 3 years on, again, the pressure started rising. So we did an ADI, a glaucoma drainage device, marked ptosis now. And still it troubled us that there was a ptosis. And the kid is now 7 years old, biopsy controlled on 3 meds, cornea clear, but the ptosis was troubling. And then we screened by the time we had access to whole exome. And they said there's no variant for the PCG, but this is the mail that I got, that it also has a 3' splice site variant in the NF1 gene. And well, retrospectively, when we lifted up his shirt, this is what I was saying, and there were cafe au laits, and they weren't there possibly when they were. This is what our pediatrician said, that many times these isolated things possibly are not there when the baby is born. So maybe you didn't notice. But to be fair and to be honest, I didn't think about this 7 years ago. Story 2 is aniridia. So this 5-year-old boy with similar complaints in the family. So he's 5 years old. You can see the edge of the lens. There's no iris. I asked the father, family history. Yeah, there are more of them. So there's nystagmus. This is what they have, tilted disc, foveal hypoplasia. And he brings in his entire family who has nystagmus and no iris and foveal aplasia as well, including the wife. So an autosomal dominant trying for a normal child produced 3 with aniridia, and I said, please stop, because it's autosomal dominant. You'll probably pass it on to the next as well. So this was garden variety aniridia. We just patted ourselves on the back, and that was that. And then this 3-week-old preterm came to us, 28-weeker, bilateral hazy cornea, no ROPs. Bad corneas, pressures, anyway, very, very. And what we noticed was aniridia. This was on table. You can see the edge of the lens there. And we said, okay, poor guy, preterm aniridia. So a bilateral combined trab with trab. We couldn't examine the fundus with this cornea. We did a combined trab with trab, which was a standard procedure. The cornea cleared. We saw the clear lens. We saw the aniridia. We said, okay, good. And then we did a flying baby ASOCT. This is our new toy, and we love to see the stumps of the iris, which were not going up, thankfully. So it wasn't occluding the trabecular meshwork, and we were all right. But lo and behold, we said, let's do a genetics, and we got a FOXC1. And then we suddenly noticed telecanthus. We suddenly noticed a flat nasal bridge. And then as the child grew up, we noticed he had redundant umbilical skin. And when we asked the mother, he'd also had surgery for a ventral hernia. So this we called a possible aniridia variant of Axenfeld-Rieger, because then when we looked back to this was a complete gene deletion. So when we read up literature, we found very little, but on consulting other people and other consultants across, they said possibly a complete gene deletion of FOXC1 possibly results in a complete absence of iris. So aniridia is something which is troubling me now. Is it a disease or is it a phenotype? And I tend to believe it is now a phenotype, and we should start rethinking ourselves in terms of whether aniridia is a disease, because this boy has no limbal stem cell deficiency, he has no foveal hypoplasia, he has no nystagmus, and I think he's going to do better than the aniridia which we know. So here's a clinical case 3, again, very cloudy cornea since birth, intense epiphora photophobia. This spindle-shaped, this is something which I want, if any of you are looking at congenital glaucoma or early childhood glaucoma, if you have this spindle-shaped corneal scar, think of CYP1B1 cytopathy. More often than not, we've seen enough in neonatal onset CU, but we weren't thinking of that because we saw no iris and we thought this was aniridia. You see this lens, but this should have alerted us. But we learned with time. We did a bilateral combined trab with trab, and sure enough, you have CYP1B1 arginine 390H, and this is the Sanger's confirmation. And we are the ones who talked about neonatal onset congenital ectopia in UVA. We are the ones who said it may be caused by a distinct CYP1B1 pathogenic variant. And this is the pathogenic variant. And yet when a baby is with us, we don't see the cornea and we just look at aniridia and we call it aniridia. So in the 10 months follow-up, this is the spindle-shaped scar which remains. So you see all the corneal edema has settled because the pressure is better, but this scar is going to stay. And this child doesn't even require a PK and doesn't require an optical iridectomy because there is such severe iris hypoplasia that you can see the clear lens here as well. But this is classically CYP1B1 cytopathy and neonatal onset CU with severe iris hypoplasia. So this is another variant of, again, aniridia being a phenotype and not a disease. So I'll just end with this possibly story 3. This boy was operated for congenital glaucoma again. And the parents were not happy because he's 1.5 years old and the corneas are exactly as it were. And then they come in with their 1-week-old daughter. That's his little sister, and she has the same haze. And the confounding is that he's also rubella positive. So it takes us in another direction, thinking that this is possibly rubella keratopathy, though it doesn't, the phenotype doesn't look like rubella, but anyway, he's rubella IgM positive. So he has a diffuse corneal haze, and this is the little baby. But there's no limbal stretching. The pressures are fine. The media is hazy, but you can see the disc, which is about 0.3, and the retina is all right. So the gut feeling is there's something else. And again, I said the new toy, and we started looking at the trabecular meshwork on the SOCT. We can do this on the swept source OCT by using a flying baby technique. We just hold the baby, and even if it's 3 weeks old, we can manage to get decent pictures like this. And we saw that there's no high iris insertion. The trabecular meshwork is clearly in apposition with the aqueous, though there is a diffuse corneal haze. And we thought there's something else. It's homogeneously thickened, 1004 and 1014. No angle dysgenesis. We thought of shed and said, let's see what the genetics says. And it did say shed. So you can have other tools and other toys, but you have a gut feeling that something is not right. And the older brother was shed as well, but unnecessarily had already elsewhere undergone a combined trab with trab as well. So it's been a wonderful early baby steps of journey. I know there's so much that we don't know and so much to learn, but it's effective in identifying phenotypes with high and low concordance. That's the one takeaway that has happened, that I know now that, this is going to be this, and unless required, you don't really. So the era of questioning everything that comes to you is, I think, over. That excitement of dekhe to kya hai is a little less. Minimal phenotype reclassification, which means accurate phenotyping, is crucial. I think that's very important for a clinician. Understanding it in a specific population, I think, is essential to expand the genetic database. That's important. And phenotypes with high concordance should benefit from small targeted gene panels. You could just do that one gene if the parents really wanted to know. And those with low concordance like Peters may yet require whole genome sequencing, because I don't think we are looking at anything at just the exons. I think something else is going on as well. So that's about it for all that. Thank you. And a shout out to all my residents who really go crazy with me all day. Thank you.
Thank you, Sushmita ma'am. Again, a very mesmerizing presentation from you. So many pearls packed into one presentation. So whenever, these kind of presentation, may I go back to, in my mind, all the cases where I missed this finding, they come. So this spindle-shaped corneal opacity, when you are saying that, I'm remembering, oh my God, so many glaucoma patients I have seen this in the spindle shape. I used to think, oh, it's because of the chronic edema, or it is late surgery that they have this. But I think this is from birth, right?
Yes, it
That
is.
they are born with this kind of
newborn. I think Ken Nischel has coined the term CYP1B1 cytopathy for them.
cytopathy.
He thinks that there are some variants of the CYP1B1 which specifically target the cornea, and they are scarred when they come. So the edema goes down. You've seen the edema settles well, but the scarring remains. So that's
remains. Yeah, I used to think always it's because of long-standing edema and then the scar has happened, or like the way it happens in, after sudden eye drops in congenital glaucoma, that can happen. So anyways, very great pearls. One more thing was that, like you're mentioning, that the aniridia as a phenotype, that definitely I do see in some of the patients, and even and most of them, they have this anti-segment dysgenesis phenotype overlap kind of a thing, like a keratoirido lenticular dysgenesis. Along with that, a very small stump of iris.
Yeah. So I would be very happy in a non-PAX6 aniridia, because a non-PAX6 aniridia has so much more visual potential and potential for a normal life, because PAX6 aniridia is terrible. So I think we now are at a position to differentiate between, I don't know whether we can call it that, but we've started calling that there's aniridia because of phenotype, there's no iris. So clinically, but it's not the disease. It's not the PAX6 foveal hypoplasia, possibly Wilms tumor. That is associated with the ELP4, which is downstream, and its regulator. So many of them would be just ELP4. We didn't understand that until we read it up, that ELP4 is a regulator of the PAX6. So sometimes, so those are the bad phenotypes to have. But if it's non-PAX6, I'm quite happy. If there's no nystagmus, that's my clinical purpose. If your child has no nystagmus and there is no iris, and there's no iris, there's no nystagmus, the nystagmus is because of foveal hypoplasia. So if there is no nystagmus, then it's good, and it's not PAX6. You don't need to rush him for Wilm tumor surveillance. You don't need to worry about limbal stem cell deficiency. You don't need to put in primary tubes. You can go ahead with your combined trap, because it's not PAX6. The absence of iris.
Also the presence of fovea, that's what I was saying, that if the fovea is also there, that will definitely, they won't have a nystagmus. So either you look at the fovea or see that there's no nystagmus, and definitely it's a non-PAX6.
Sometimes when they have very bad corneal edema, you might not be able to see it. And the other thing I've noticed is aniridia PAX6 hardly ever comes with a bad white cornea. I've seen them, they have this hazy, grainy, and very thick corneas. So even your IOP measurement is a problem. You might have 700, 750 microns cornea in aniridia, and then be very careful of diagnosing. So you need to see the disc very carefully. Like the family that I showed you, all of them had very good discs, but their pressures were all recorded as 26, 28, which is why they were referred. But they had 750, 800 micron corneas. So we just held on that it's a rigid cornea, it's a thick cornea. If the disc is fine, let's hold on. Do nothing as yet. This entire family is, and they have the exact same variant. So I hope all of them do. And the mother has no glaucoma. She's lived. She's produced 3 children with her aniridia and nystagmus and 660 vision. So we hope the children will also have some useful life and useful vision. Yeah, but it's mind-boggling. It's such an amazing thing that has come in that we can so much.
I think Dr. Deepika has a question.
Yeah.
Yeah. Hi. Thanks, Ria. Ma'am, thank you very much. It was a very good overview of glaucoma, and I understood a lot from this. I'm not a glaucoma person, but I understood a lot. I had this one question, ma'am, related to basic genetic testing, how you have approached. I see that like the summary and how you have presented, there was a reasonable concordance with the phenotyping and the genotype which you found.
Yeah.
Unlike retinal dystrophy, which I work on, where there is a lot of heterogeneity.
Yep.
So, like, was for all the cases, was it a whole exome sequencing, or you did a anterior segment dysgenesis panel, or clinical exome, or just the whole exome sequencing for all, ma'am?
So till about 1.5 years ago, the whole exome was quite expensive, and we used to be doing clinical exome for most.
Okay.
But from the possible beginning of or middle of last year, the whole exome has been cheaper than what the clinical exome used to be. So now we've started whole exome, but frankly, let me tell you, at least for the glaucoma, most of the genes which were covered in the clinical exome, I mean, most of the genes covered in the whole exome are covered in the clinical exome.
Okay.
And having shifted to a whole exome, I haven't seen so much of a difference that what I was missing on the clinical exam, dekha whole exam se ab mil gaya. I haven't seen that. But I don't think they have targeted gene panels in India, at least for glaucoma, they're not. I'm trying to tell them to just make a 20 gene panel. That's all I need. But they say, I suppose it's not cost effective. But right now, whole exome is being offered to us very reasonable, and we are doing whole exome.
Okay. Thank you, ma'am. And with respect to what you saw in the Indian cohort, like our cohort, was there like a huge difference between what was published before for congenital glaucoma compared to what you saw in your cohort, ma'am? Just to understand the genetic heterogeneity between the populations.
What differs is, I think, the variant, because when we search, especially when we did a lot of work on the congenital ectopia and UVA, because I didn't find that anywhere. And arginine 390H, for instance, is a founder mutation from Pakistan. Okay. And the only other paper that I found of a similar iris phenotype is from Dr. Arif Khan. He was in King Khalid at that time, and he called it a partial aniridia. And he also said that it is due to biallelic CYP1B1 mutations, which run in families, but their variant was G61E. And if you look at Dr. Sirisha's patients there from LV Prasad, they have a lot of G61E as well. So it's clear that our ethnicity is a Northwestern Indo-Aryan, and this migration is maybe they get a lot of patients from the Gulf as well. So maybe that's a reason, because we found not a single G61E. So that's just an example that even if the gene is the same, many times the variants differ. I'll give you another example, that myocillin, because there was a report of digenic myocillin variants for CYP1B1. So we did many years ago, we had a DBT project in which we did just CYP1B1 and myocillin. And the myocillin variants which were reported as digenic, and we also did controls in that, were present in almost all Northwestern, and I took only Punjabi Sikhs. So I took the cohort of normal, and it was easy for me because 90% of PGI was Punjabi Sikh, and I took all the sisters and attendants and everybody ka blood sample leke, because it was free. And some made the myocillin variant, which was considered to be digenic with CYP1B1, was there in normal people. So that was a snip in our population. So I got to know that a Northwestern Indian Jat Sikh population is what Pakistan has. So that's a very different cohort. And I think ethnicity has a lot. RPC's data is absolutely mixed, because I think everybody goes to RPC.
RPC, correct.
Yeah, but LVP has predominantly South Indian, so their ethnicity is completely different. We have completely Northwest India, Pakistan, that ethnicity. So it's very interesting that genes can also make you. It can be a very nice historical read if you really read some of those papers, it's very nice how they've migrated.
Yeah.
Yeah, thank you, ma'am. Thank you very much. It was very nice. Thank you, ma'am.
Because I shifted from my fellowship here, so many of diseases I just don't see here,
Yes.
which I used to see there, and even the phenotypes are quite different.
Yes.
Even in squint, we see a lot of myopic strabismus fixes there, where where the eyes go inside because of a very high myopia. I have seen hardly 2 cases in 10 years, and there every year we used to see so many. So definitely ethnicity, consanguinity, all these matters a lot, as you rightly mentioned. Deepika, what is your choice for your testing? Like, do you prefer panel, or now you're also doing whole exam for retinal dystrophies? Because at least I know that retinal dystrophy panels are still quite well defined in most of the labs.
Yeah. Yes, Dr. Shailaja, like for the same reason, I wanted to take Madam's opinion also. As of now, like I've worked on this recently, I spoke to Ria as well regarding this. Currently, there are labs, there are panels available, at least for retinal dystrophy, like you were saying. There are also panels for corneal dystrophy and anterior segment dysgenesis. And also ectopia lentis, vitreoretinopathies. There are panels. So I checked with the lab to see if those panels can be offered at a lower cost, because we are trying to analyze a lesser number of genes, like ma'am was saying, just the 20 genes. So, but it is not cost effective for the lab. For example, I will not be able to produce an aniridia case of about 20 in the same month. It varies from population to population. So the lab said that for them to create the panels and analyze panel wise, it is not cost effective for them. So they are offering this comprehensive ophthalmic panel, which covers about 700 genes, which has everything like retinal dystrophy, corneal dystrophy, congenital glaucoma, everything at the same cost as close cost as clinical exome sequencing. So the best cost effective panel what they can offer is comprehensive ophthalmic panel. We are trying to work on a retinal dystrophy panel with updated genes, but for other disorders we are still not sure because the labs are not offering.
Yeah, so that's the problem we also have. Like, especially, I mean, retinal dystrophy still, can have a defined panel, but most of these anterior segment disorders, they have quite a phenotypic overlap. Like Dr. Sushmita is mentioning, glaucoma maybe could be there, but many times with anterior segment, other forms of anterior segment dysgenesis and all, they are quite overlapping. So if you have a very good accurate phenotyping, like after 7-8 years now Dr. Sushmita would be fairly confident that because of your learning from the previous testing, but then those who are trying to explore and they're not very good in phenotyping, then they get stuck with these small things that what if they order a panel and then it doesn't come positive, then what?
It's reverse
should we have looked at other genes? Yes, should we have looked at some other genes? And sometimes these are very rare things, and that's why this forum might help us to cross-learn from other departments, from each other. Like, these are the things which are there, and we should talk about them more often. And this would probably help us learn to narrow down our testing, or maybe even not test in many of the patients, saying that, oh, this phenotype matches to this kind of gene, and no need to even test for those kind of patients where you have like 100% concordance, as you were mentioning.
So Deepika, like a case in point was neurofibromatosis, which would not have been in their glaucoma in their eye panel at all, which I asked them. I said, do you have NF1? They said, no. I said, thank God I did a whole exam in him.
Whole exam. Correct. Yeah, that's what we need.
Yeah, so I NF1, and there's hardly any report of neonatal onset glaucoma in NF1. All the glaucoma in neurofibromatosis is secondary to, a bulking thing which is pushing the eye, and then an optic nerve glioma, sphenoid wing meningioma, but nobody talks of a glaucoma at birth. And at birth, you have unilateral ophthalmos and whatever. So that's learning. And now I have about 3 or 4 of them who now I know. So those are the 5 that I've tested. Now, if I have unilateral ophthalmos, I look for from the thing, I look for MRI, I look for cafe au lait, I pick up shirts. It's been a very, very learning thing for us. Yeah.
Thank you.
I too have a very small question. I have had a patient of axon-filled rigor. He came to us as an adult, and it was axon-filled rigor syndrome. So he had oligodontia. He had the redundant umbilical cord. We did the mutation testing and we didn't get anything, and we sort of harped the lab once more that okay, no, you keep looking for it because the phenotype is classical. You have to have it. And you did mention in your presentation also that even for ARS, even for axon-filled rigor, you might not, the concordance rate is low. But even in such classical cases, it's possible to not get anything.
I don't know. I suppose. क्या बताऊं?
Yeah.
You know, maybe. I don't know whether it's a regulatory thing which is happening and the function of the gene is affected, like ELP4. I'm like looking for PAC6, and I've said that, and the mail comes. We haven't found any this thing to the phenotype. However, there is a variant found in ELP4. So when I get a mail like that, I go and check, and I said, "अरे ये तो उसका regulator है, हाँ, of course report it." So
Yeah.
maybe it's not FOXY1 and PTEX2, but are we looking at something else? I mean, is there something which is causing a regulatory problem? So again, like NF1 was also an email. Thank God they said that no variant, that was a report, but the mail said, look, we found something in NF1. And then I said, no, please make your report again.
Report it. Yes.
So that again, no variant becomes pathogenic because I say there is pathogenic, there is cafe response.
Yes. Okay. Do we have any other questions? Okay, I think we've run over time as well. Thank you so much, ma'am. This was great. And we too aspire to do reverse phenotyping like you. We're not there just yet, but it's amazing. And so much to learn. Thank you so much. And thank you, Sirisha, ma'am, if you're still logged in for today's session. And we will see everybody here next month in December.
Sure. Thank you so much for having me.
Thank you all. Thank you, everyone. Again, excellent session. Thank you so much, Dr. Sushmita and Dr. Sirisha. She's still around. I'm sure she must be, finishing up patients yet.
Yeah.
Okay. Bye, everybody. Thank you.
Bye.
Bye-bye.